Hello, my name is Kelly Haisley, and I'm a foregut surgeon and assistant professor at the Center for Minimally Invasive Surgery at The Ohio State University. And I'm really happy to be able to spend some time talking today about the surgeon's perspective on Barrett's esophagus and to discuss some of the diagnostic and therapeutic challenges relating to what our role as surgeons is in managing this disease. I have no disclosures to report as it relates to this presentation or otherwise. So I guess I really just have to start by asking the question of whether Barrett's esophagus really matters to general surgeons. After all, while foregut specialists may have a specific interest in this, the vast majority of practicing general surgeons, at least, do not manage endoscopic eradication or surveillance of Barrett's esophagus. And the reality is that a patient coming to you with a diagnosis of Barrett's is more likely to have received referral to GI for management of that issue. But I would really argue that a fundamental understanding of Barrett's and its position within the spectrum of gastroesophageal reflux disease is really valuable for surgeons, and in fact is an important consideration in both pre- and postoperative management of patients with GERD. Now, while in general, the worldwide population, Barrett's is fairly rare. Its prevalence is noted to be much higher here in the United States and in patients with GERD, where it might be as high as 20%. Though some of this is difficult to know for sure due to lack of standardized screening, Barrett's esophagus is affecting our patients at rates that deserve attention. And it's hard to ignore a disease that is a known risk factor for esophageal cancer, which is steadily increasing at a pace that exceeds many other common malignancies with no sign of decreasing. Now, given all of this, Barrett's has gotten plenty of attention in the gastroenterology world, and Barrett's treatment and surveillance protocols have been widely validated and published from a variety of sources. Now, these protocols concentrate on escalating surveillance for high-risk lesions and endoscopic eradication of dysplasia with EMR and RFA techniques. But you'll notice that nowhere in these published guidelines does it ever say refer to surgery for consideration of an anti-reflux operation. In fact, the most recent ACG guidelines state quite unequivocally, and that based on available literature, anti-reflux surgery should not be pursued in patients with Barrett's esophagus as an anti-neoplastic measure. However, these guidelines and a large body of published literature do show rather convincingly that reflux control is absolutely necessary for successful eradication of Barrett's, so acid medications typically are still recommended both during and after Barrett's eradication. So in this setting, I think that it's interesting to consider what role surgery might actually have in reflux control, and in fact, whether an anti-reflux operation might be better than PPIs long-term in this setting. This is because while PPIs do reduce acid reflux, they don't do anything to stop volume reflux of gastric juices, which are also known to be carcinogenic and predispose to the development of Barrett's esophagus. So please bear with me on a little tour through some basic science as I attempt to convince you why this concept may have some merit. Now, this theory is actually borne out in the history of Barrett's esophagus and esophageal cancer over the years. And despite the fact that presumably the volume and time of reflux exposure in the distal esophagus in human beings has stayed relatively similar through the years, the rates of Barrett's and the rates of esophageal cancer are rising precipitously. And this has been most pronounced actually since the introduction of H2 blockers and more recently PPIs. And while the topic of PPIs and cancer risk is a bit too much to bite off here, suffice it to say that the theory is that increasing alkalinization of refluxate with acid suppression may actually be increasing the carcinogenic potential of that same refluxate. So to illustrate this just a little bit for you, take a patient with several centimeters of visible columnar-lined epithelium in the distal esophagus. If you were to take biopsies, either optical with Cellvizio or pathologic, what you would find is that the zones where the intestinal metaplasia is actually developing is typically in that proximal area of the columnar-lined epithelium. And this differential expression of intestinal metaplasia at various levels of the esophagus is theorized to be related to differential pH levels as acidic gastric juices reflux up and are neutralized by the alkaline salivary fluid coming down. Now this, of course, being in a patient with a normal gastric pH of 2, meaning this patient is not on any acid suppression. Now physiologically what's happening is that bile acids, which are part of that volume reflux, are actually only activated in this alkaline environment and only become functional, and as a result, increasingly mutagenic at these higher pH levels. So the problem with refluxate in a patient on PPIs is that all of the refluxate is in that alkaline range where bile acids are active, theoretically making the refluxate more mutagenic at all levels. So in this setting, if PPIs don't do anything to stop the volume reflux, and in fact are creating a more alkaline refluxate that is perhaps more carcinogenic, then the question becomes, would anti-reflux surgery actually be more effective to promote remission or reduce progression of Barrett's, either dysplastic or otherwise, by creating a mechanical barrier to all reflux? Put another way, if Barrett's progression is mediated by ongoing reflux, both acid and non-acid, then anti-reflux surgery should actually help more than PPIs. So that's a nice theory, but let's look at the data. The studies that have been able to look at this, albeit small, have shown that the effect of anti-reflux surgery on Barrett's esophagus is pretty similar to what we get with medications. On follow-up endoscopy, about a quarter to a third of all cases of Barrett's esophagus will have regression once the reflux is controlled surgically, but about 10% will actually progress despite having had an anti-reflux operation. So ongoing surveillance is absolutely needed. Now, when you compare this to the medical literature, meaning PPI use, these rates are about the same. So it would seem that either option should at least be acceptable. So then what really is the surgeon's role in management of Barrett's? Well, I do think that there's good evidence that anti-reflux surgery is as effective as medications for Barrett's. And let me stress here that neither one is a guaranteed solution for Barrett's. Neither one is actually a treatment for Barrett's. They are only treatments for reflux. And in both cases, patients require ongoing endoscopic surveillance. But the question for me is really which patients are going to be best suited for surgical intervention versus medical intervention, as I really believe that not all Barrett's cases are the same. Should we be wrapping all patients with Barrett's and try to really control that mutagenic refluxate that might lead to cancer? Or should we be focusing towards or perhaps against patients with dysplasia? And if we are to wrap dysplastic Barrett's, when is the optimal time to do it? So let's go through just a few of those questions, and I'm going to try to give you my best answer. So question number one, is the presence of non-dysplastic Barrett's alone an indication for anti-reflux surgery? Well, one of my main mentors, Dr. Steve DeMeester, would say anti-reflux surgery should be strongly considered in any patient with intestinal metaplasia of the esophagus or cardia. And this is because you absolutely cannot have Barrett's esophagus without the presence of gastroesophageal reflux disease. In fact, the pathologic conformation of Barrett's is diagnostic of GERD, even in the absence of pH testing, and you do not need to get a pH test on these patients. However, as we saw previously, rates of remission and progression are about the same as medical therapy. So my general consideration for patients with non-dysplastic Barrett's is that these patients should be considered and counseled the same as any patient with GERD, and that surgical indications are related to carefully counseling about symptoms, medication tolerance, and quality of life. Now, I personally do not push anti-reflux surgery on an asymptomatic patient with non-dysplastic Barrett's, though I do counsel them that surgery is an acceptable option if their goal is to remain medication-free. So question number two, what about dysplastic Barrett's? Is surgery helpful either during or after endoscopic therapy? Well, Dr. DeMeester is back telling us that good reflux control is necessary for successful ablation of all intestinal metaplasia and restoration of that healthy neosquamous mucosa. And the literature would support that fundoplication after successful complete eradication of intestinal metaplasia does provide similar durability to PPIs alone. However, in challenging cases, it may be very hard to achieve successful endoscopic eradication or CRIM while there is so much ongoing reflux between ablation treatments. This can be particularly true in the setting of large hernias or very long segment Barrett's. In cases like this, it's been shown that performing an anti-reflux operation in conjunction with RFA actually does increase the likelihood of achieving a durable ablation. And furthermore, in patients who have gotten CRIM after their ablation of dysplastic Barrett's, it does seem that fundoplication actually decreases the rates of intestinal metaplasia recurrence compared to medical therapy alone in this selected group. So we can conclude from this that anti-reflux surgery is at least as good, if not better, than PPIs in maintenance of Barrett's eradication after RFA of dysplastic Barrett's epithelium, and that anti-reflux procedures may be superior to PPIs as an adjuvant tool during endoscopic eradication of long segment and refractory intestinal metaplasia. So question number 3 then. Well, what about the progression from Barrett's to esophageal cancer? Well, a very prominent gastroenterologist who I have great respect for and who shall remain unnamed, during a heated debate at the American Foregut Society last year, stated unequivocally there is no proof that anti-reflux surgery prevents esophageal cancer deaths or prolongs survival better than medical therapy. Now, I will concede that there is no level 1 evidence that fundoplication prevents the development of Barrett's or esophageal cancer better than medications in the general GERD population. But there are several problems with these data, or more appropriately, the lack thereof. Unfortunately, there are no randomized controlled trials that exist to address this question. There's also undoubtedly some confounding by indication, as more severe reflux, which may be higher risk for cancer, is more often treated by surgery. There's also some interesting data that suggests that a failed anti-reflux surgery might actually be worse than none at all, as far as increasing the risk of cancer above baseline, which we don't really have time to get into here. But I would argue that patients with Barrett's esophagus, and particularly those patients with dysplastic Barrett's esophagus, may not be the same as the general GERD population, and perhaps we should be thinking about the risks and benefits of surgery versus PPIs a little bit differently in this group. And this was actually published in the Annals of Surgery in 2016, in which a systematic review and meta-analysis was done of anti-reflux surgery in GERD patients looking at cancer risk. And what they did is they subdivided this into GERD patients with and without Barrett's esophagus. And what they found was in those patients with Barrett's esophagus, anti-reflux surgery actually did significantly decrease the risk of development of esophageal adenocarcinoma, considerably more than the effect that it had on the patients in the general GERD population. And this article did conclude that anti-reflux surgery may prevent esophageal cancer actually better than medications in patients with Barrett's specifically. So in conclusion, we know that reflux control is necessary in the management of Barrett's esophagus, and that surgery is relatively equivalent to medical management in terms of Barrett's remission and progression. However, there also seems to be burgeoning data to suggest that surgery may actually have advantages over PPIs, particularly in the setting of dysplastic Barrett's, eradication, prevention, and prevention of recurrence. In fact, surgery may in fact decrease the risk of progression to cancer in specific Barrett's populations as well. So taking all of that into consideration, here is my surgical perspective on who to wrap. I offer surgery to patients with non-dysplastic Barrett's whose symptoms are significant and refractory to medical management, just like the general GERD population. In cases of dysplastic Barrett's, I offer patients anti-reflux surgery either following complete eradication of their intestinal metaplasia or during eradication of their dysplasia if that dysplasia is refractory or very long segment and I am certain that there is not a cancer that is hiding in there. But I do just have to end on a public service announcement. I mentioned this before, I want to say it again. Anti-reflux surgery is not a treatment for Barrett's esophagus, neither are PPIs, particularly in the cases of dysplasia. If you have a patient with Barrett's and high-grade dysplasia, they require endoscopic eradication above and beyond any of your attempts at anti-reflux control, and they require ongoing surveillance following your anti-reflux operation. because your procedure did not fix the Barrett's, it just fixed the reflux. So keep this in mind when you have these patients. You don't just get to say goodbye to them afterwards. You need to make sure that they're getting appropriate Barrett surveillance afterwards. So thank you so much to everyone for the opportunity to present, for embracing this new format that we're doing, and to SAGES for allowing me to speak on this really interesting topic that I actually find quite near and dear to my heart. All of my contact information is here, and I'm more than happy to talk with anyone about this. If you have additional questions or concerns or would like additional information from me, please don't hesitate to reach out. Take care of yourself, and go Buckeyes.